Actually, let me grab the scalpel and I'll show you. Here we go again. Man, COVID was brutal. Just brings back so many bad memories.
Nick Bradley, 19, found unresponsive by parents, barely breathing with pinpoint pupils, bradycardic at 38.
Pupils responded to Narcan, but we tubed him when his respirations didn't pick up.
The guy has pinpoint pupils, he had decreased level of consciousness, and he wasn't breathing, so this would be an opioid overdose until proven otherwise. The thing that is a little bit atypical with this presentation is that his heart rate was low at 38 beats per minute. That's not super typical for a regular opioid overdose like fentanyl or heroin. But we are starting to see this very frequently in what we call trank dope, which is a combination of fentanyl with medetomidine, which is an animal tranquilizer, and that can cause severe bradycardia and low blood pressure. So typically naloxone or Narcan, which is the antidote for opioids, will reverse the fentanyl or the opioid component, but it won't do anything for the tranquilizer component, and the person will stay with decreased level of consciousness. Sometimes they do require an advanced airway, like an intubation like this.
Pupils are 6 millimeters non-reactive.
So that's not a good sign if someone's pupils are dilated. 6 millimeters is quite dilated, so 3 millimeters is what we would consider kind of to be average if you're just like speaking to someone. So 6 millimeters is like very, very dilated, and if they're fixed, meaning that they do not constrict with shining light into it, that is a pretty bad prognostic sign, meaning that the brain stem and the core brain function is not working.
64, BP is cycling.
No response to pain, GCS3.
Does that fit any toxidrome?
No. If it was just opiates with Narcan, he'd be breathing on his own.
That's correct.
Beta blockers shouldn't give pinpoint pupils.
Maybe parents had some prescription meds in their bathroom.
They're on their way.
ETA 5 minutes. Close trauma tier 1, ETA 5 minutes.
That's a stand-up scooter rider versus car door, no helmet.
No blood in the belly, no pericardial effusion, and lungs are up.
Hemo Q's good, 15. BP 84 over 58.
Okay. What's your plan, Dr. Collins?
Push dose epi, 0.1 milligram, Foley for urine, stabilized for CT, and throw a wide net.
So that's correct. If the person's blood pressure is really low and they have a slow heart rate as well, we would start vasopressors. Push dose epinephrine or push dose epi is totally appropriate in this case. You would do that to actually augment the blood pressure and the heart rate to keep the patient's vital signs a bit more stable so that you can try to figure out what's going on. And the other thing that we would want to do in this situation is definitely get a CT scan of the guy's brain immediately to try to figure out what's going on, because it's not totally normal for someone's pupils to be completely pinpoint and then go to be completely blown. So if I was the doctor in this case, I would still suspect that there's some kind of toxidrome or an intoxication. And based on what I see in the downtown core of Vancouver, the most common thing that I see is trank dope.
Flaccid paralysis of all 4 extremities.
So if the person has flaccid paralysis of all 4 extremities, it means that even if you do painful stimuli, like you're squeezing on their nail beds, on their fingers and their toes, and they're not withdrawing, you would be really concerned that maybe something else is going on, like potentially even like a high cervical spine injury, but that wouldn't be totally in keeping with the person being completely unconscious like this. I would suspect that this is either a really bad toxidrome or a bad brain.
No eye movement with ice water.
So no brainstem function.
So what she's doing is what we call cold calorics, where you squirt cold water into someone's ear canal and to see if it actually triggers what we call a nystagmus, which is where the eyes start to beat very rapidly. It's one of the tests that we do to see if there's any signs of brain death. And if there's no eye movement with cold calorics where you're spraying the water in, it's a clear indication that someone has died of, essentially is brain dead now.
Samara, escort him to CT.
What they're going to do next is they're going to send this guy to the CT scanner to look at his brain. And in this scenario, given the information that we've been given, I'd be very suspicious of a really severe anoxic brain injury. I see this unfortunately all the time with the opioid crisis, where someone has taken opiates, they stop breathing for a very long, prolonged period of time. And that causes essentially starvation of the brain of all oxygen and nutrients for such a long period of time that they essentially die of brain death. You can essentially keep their body alive on machines like ventilators and different medications, but nothing that you would do in that scenario would actually bring their brain back to their previous baseline, or essentially revive the brain, so to say. And so typically what we have to do is speak to the family to see if they'd be willing to donate the organs to other people. Whether they do or they do not, we would essentially withdraw care and allow the patient to die by natural means. And it certainly is like one of the saddest things that I see on a pretty frequent basis during the whole opioid crisis, because a lot of the people that are dying in this way are young, otherwise healthy people.
Just received word your son's head CT is normal.
First thing I want to say is a normal CT head in this kind of situation where we've already done tests to establish brain death with cold calorics and no reaction to the pupils doesn't necessarily mean that the kid's going to be fine, because oftentimes it takes quite a while, like sometimes hours, for the brain scan to actually show findings of anoxic brain injury or, really bad brain injury.
Blown.
So
We
kid
don't
still has
know
blown
how long
pupils.
He was at home without breathing. Are you sure that he didn't take anything that could have caused it?
No, he's a good kid. He's in college.
Good kid doesn't necessarily mean that the kid's not using drugs, and someone who's using drugs doesn't necessarily make them a bad kid. I do understand why they're including that, but I think drug use and experimentation is just so ubiquitous in today's society. So I think it's just so important for parents to have an open discussion and dialogue about substance use and the potential consequences of it. I think I just saw recently a post on Instagram of a young kid, I think she was like 14 years old or something like that, and she had bought what she thought was a Percocet, and she took it, and it ended up being completely laced with fentanyl, and she ended up dying of anoxic brain injuries. So this is something that's very common, and just really emphasizes why we need to have open conversations with all of our friends and families about this.
It's a drug test, and it is positive for fentanyl.
Well, Nick doesn't do drugs.
There are a lot of pills that are sold illegally that have fentanyl, not just painkillers. Xanax, Ativan.
Not our son.
I think his pinpoint pupils just grew into balloon pupils from brainstem death. Not much older than Jake.
Don't go there.
Hard not to sometimes.
That's so true. Like whenever you see patients that remind you of your own family members or your own kids or your parents, it really hits differently. Like it's so hard for me to see kids around the age of like 3-4 years, because it always reminds me of my own son. Anytime you see that kind of tragedy, it just hits completely differently.
I gotta go tell those parents their 18-year-old son is brain dead.
What are you going to say?
I'm going to say that it's likely, but we still need to do an apnea test and a cerebral perfusion study.
What are we praying for miracles today?
They need time to process before they can accept what's happening.
Dr. Robbie is right in this scenario. I agree with him that especially when a child is dying and brain dead, even though most patients, we wouldn't do every single test to test for brain death, in a case like this, I would be doing cold calorics, I would be doing apnea testing, and I would be doing cerebral perfusion studies to make sure that the parents know without a shadow of a doubt that the kid is dead and that there's no coming back from it. Because I think if there's any amount of doubt and you withdraw from care, that can be incredibly psychologically traumatizing for our patient's family. That's one of the hardest things of this job.
Your father has pneumonia and a condition called sepsis. It means that the bacteria has spread from his lung to his bloodstream.
Actually, what Dr. Robbie is describing, where the infection spreads from the lung to the bloodstream, is actually what we call bacteremia. Sepsis is actually in an abnormal response from the body to the infection, where you don't necessarily need bacteremia, where the bacteria seeds into the bloodstream, but essentially it causes a widespread inflammatory response throughout the body, where essentially the blood pressure starts to tank, and the end organs like the kidneys, the lung, the brain, the heart can all become really affected because they're getting decreased blood perfusion.
Is this his baseline?
He has good days and bad days.
Your dad has an advanced directive expressing his wishes, which says that IV fluids and medications are okay, but no artificial life support, no CPR.
But if he can get better in a week, then put him on a machine.
Sometimes allowing for a comfortable natural death can be the most humane path.
This is an ethical situation that I see all the time in the ER, and I've seen these kinds of situations tear apart families because the living children of an elderly person who has clear goals of care that's already been very clearly delineated cannot agree on the best course of action. And my job as a physician is always to encourage the adult children to try to respect the wishes of their loved one, and not to try to change around the goals of care because they want extra time with the person. Because again, like the thing that I often tell them to come back to is that our goal is always to try to maximize the amount of quality life, not to maximize the quantity of life. And oftentimes, if you do extend quantity of life, is you're actually extending suffering to the person who is remaining. So in this situation, I'm already getting the sense that the son wants to respect the goals of care that's already been laid out by the father. The daughter is actually trying to go against that and advocate for critical care, which is intubation and CPR, which is not always in a patient's best interests.
What is happening?
His oxygen levels are dropping.
I don't remember where I parked.
So it looks like Mr. Spencer is becoming delirious. This is something that often comes hand in hand with sepsis in elderly patients. This is the point where you would start to have really serious conversations with the son and daughter about how they're going to manage it. Again, I would emphasize that we should respect the patient's wishes and continue giving him things like IV fluids and antibiotics. And if he continues to deteriorate, we switch him over to what we call comfort care, where we make sure that he's not in any amount of discomfort, anxiety, or pain, and allow him to pass by natural means.
Do you know where you are?
Dad, look at me. What's my name?
IPAP 15/5. Step out.
BiPAP is non-invasive positive pressure ventilation. Essentially, it's a mask that seals around the face and pushes air into the lungs, or oxygen into the lungs. It's pretty much the highest form of ventilatory support that we can provide outside of actually putting a tube down into his trachea and putting him on a ventilator.
Let's just hope the BiPAP works.
And if it doesn't?
Then I would need to know your decision about using a breathing machine.
A little bit of background. I was always taught never BiPAP a pneumonia. The research proves that if you give BiPAP to people with bad pneumonia, it actually causes higher mortality because oftentimes it delays a necessary intubation. In this kind of scenario where the goals of clear are not totally clear and you're just trying to buy time to have this discussion with the son and daughter, I think it actually would be quite reasonable to BiPAP your patient with pneumonia so that you can kind of like ease the shock of the patient's death and, you know, just give the son and daughter just a little bit more time to be with their father as he transitions to death.
He expressed his wishes in writing. Do not intubate.
We're thinking try it for a week.
That would be a very painful week with a very uncomfortable tube down his throat. This is your father. It's your decision to make. We will keep him as comfortable as possible.
And he can recover from this.
What my sister means is that we're still deciding the best thing to do.
Dr. Robbie is demonstrating what we call patient-centered care, where he's actually keeping his own biases and values and preferences out of this scenario and trying to present the options to the son and daughter. I think he's doing actually a really good job of that. These situations can be incredibly difficult and strenuous on the family members of a dying patient. I think that Dr. Robbie is presenting all the different facts in a very neutral and compassionate way.
We want you to put our father on the breathing machine.
Even though that goes against his desires to not be intubated?
We're not ready to let go yet.
I may have to honor his advance directive.
No, you have to honor our durable power for healthcare.
Okay, you can sit with him until we're ready.
This is the unfortunate reality, is that if someone has goals of care that says that they don't want critical care, including intubation and CPR, and they are unconscious or delirious and aren't able to provide consent, but the power of attorney, like the living adult children, want to override that and change the goals of care so that he does get intubation and CPR. Most oftentimes we will listen to the power of attorney and go ahead with that, even if the written document says otherwise. So this is just one of the really tough, challenging things in medical ethics when you have a really sick patient in front of you and you don't have the luxury of time to be able to go back and forth on what's best for the patient or what's best for the living family.
They want to torture him?
I explained all that.
Call the ethics committee. They'll agree with us.
No, you're probably right, but we don't have that kind of time.
That's exactly what I said. If you've ever felt overwhelmed trying to understand your health, figure out whether something needs medical attention, or make sense of all the conflicting advice online, I built medical school for you. Over the course of my career, I've cared for tens of thousands of patients during some of the most stressful moments of their lives. And one thing that I see over and over again is that most people are forced to make important health decisions without the knowledge or the confidence they need. And that's why I created medical school. Medical School is an online learning community designed to help you understand your body, take control of your health, and navigate healthcare with confidence, even if you have no prior medical knowledge. Inside, you'll learn how to prevent and manage common medical conditions, recognize when symptoms are serious, care for your kids and aging loved ones, and make better decisions when health issues come up. You'll also be part of an active community of everyday learners, parents, caregivers, healthcare workers, and health coaches. And you'll have direct access to me through community discussions and live Q&A sessions twice a month. Joining medical school is completely risk-free. Every new member receives a 7-day free trial, giving you access to the community and educational resources so you can explore everything before making a commitment. So if you want to live a healthier life, navigate healthcare with confidence, and become the medical go-to person in your family, workplace, and community, click the link below in the description and join medical school today.
You can rest in the hall till we get your labs back.
Parents must be proud.
You know, I was the first one in my family to go to college. They sacrificed a lot to get me here.
So I can definitely relate with everything that Whitaker is saying. Like, I'm the first person in my family to become a doctor or go into healthcare. And yeah, my parents are very proud of me. So yeah, it's been a great privilege to become a doctor.
There was a gallstone present on POCUS.
Why did you order the EKG?
Nurse suggested it to rule out any cardiac issues.
Well, good call. Nurses know what they're doing. Never hesitate to listen to them.
It's definitely one of the lessons that we give to all of our medical students, to never think that they know more than nurses, because a lot of the nurses, especially the senior ones, have been working and doing this job for such a long period of time that they actually have a much stronger knowledge base than a lot of the junior learners, whether they're medical students or junior residents. But everything that Whitaker suggested doing for the right upper quadrant abdominal pain, including the ECG and the cardiac workup, is totally appropriate.
No helmet, got doors riding an e-scooter. Obvious facial fractures, but alert and oriented with good vitals.
Larynx shifted to the right, no crepitance.
This guy was in a really bad electric scooter accident versus a car door, like a blunt polytrauma. We see this again all the time, especially people that are not wearing helmets when they're riding these electric scooters, which go really, really fast. Like, they almost go, I think some of them go higher than 40, 50 miles per hour. So you can get some really, really bad traumatic injuries from this. Santos identified that the person's trachea is deviated from the midline, so this would make us concerned that the patient has a tension pneumothorax or a collapsed lung, which is actually causing compression of all the structures inside their chest cavity and pushing it to the opposite direction. The management for that would be to perform what we call finger thoracostomy, where we use a knife and stick our finger into the chest cavity to relieve that pressure. Sometimes we'll do what we call a needle decompression, where we use a large bore needle and just stick it into the chest and wait for some air to escape. But that's something that is kind of falling out of favor in modern medicine.
I'm gonna stick something in your nose to stop the bleeding.
He's inserting what we call a rapid rhino. It's essentially an inflatable balloon where you can actually tap a knot or cause pressure to any bleeding structures inside of the nose. We use this very frequently for bleeding noses in the ER. With someone that has really bad facial fractures like this and a blunt head trauma, sometimes we actually wouldn't insert anything into the nose, including a rapid rhino, because if there's a basilar skull fracture, or like the base of the skull is actually broken, there have been cases where if you insert an NG tube or rapid rhino or other objects, it can actually penetrate through the base of the skull and stab the brain. He's got a Lefort fracture.
4-3 fracture.
Lefort fracture comes in 3 different categories: Lefort 1, 2, and 3, which has different segments of the face that's actually floating. The way that we would test that first is if there's tooth malocclusion when the person opens and closes their mouth like this. And the second thing is if you actually grab the maxilla or the top shelf of the teeth and you pull it, it's completely loose and floating. So this person has at least a Lefort 1. They identify that the person has Lefort 3, but you actually wouldn't be able to tell if it's a Lefort 1, 2, or 3 until you've actually done a CT scan of the face. So that's a little bit inaccurate. What Dr. Robbie is saying that they should do is prepare for a rapid sequence intubation and a double setup. A double setup is where we get everything set up to perform a normal intubation, but if you aren't able to actually identify the larynx and push the tube down the regular way through the mouth, you would already be set up to perform a surgical airway where you cut through the front part of the neck and insert the tube there, which is called a surgical cricothyrotomy. A couple of months ago, I posted a simulated resuscitation of a child who came in with a failed airway requiring a double setup and a surgical cricothyrotomy. So if you actually want to see how this is performed with a real medical team, you can go check that out on my YouTube channel.
You don't cric a laryngeal fracture.
There's a lot going on here. There's so much swelling in the upper airway that they can't get a proper view of the larynx. And in a true double setup, you would have the most experienced airway operator or intubator actually performing the intubation, not Mel, who's a first-year resident. So that's the first thing that's actually very, very inaccurate here. We wouldn't jump to a cricothyrotomy, which is a very aggressive surgical maneuver to put a tube down into the front of the neck, unless we've actually had our best chance of looking for the airway with the best airway operator. So I find this a little bit hard to believe because someone with a Lefort 3 fracture to their face, who has a bloody upper airway, who's coming with trauma, and you can't actually manipulate the airway, you would already want to have probably the attending performing that airway. I probably wouldn't even let my third-year residents perform this kind of intubation unless I really, really trusted them.
Okay, now we're going to make a horizontal incision across the cricothyroid membrane.
End tidal CO2 is yellow.
Yellow is yes, nicely done.
Okay, so what they just demonstrated is a very old school method for performing a surgical cricothyrotomy or even a tracheostomy for that matter. Where they're using trach hooks, they're using retractors to do this, but oftentimes in an emergency airway situation, you don't have the luxury of having all these different equipment prepped and ready and at the bedside to perform it. So most oftentimes we would perform what we call a scalpel finger bougie method to secure that airway. Actually, let me grab the scalpel and I'll show you. The first thing that's inaccurate about the way that they demonstrated it is Mel is holding the scalpel like this. And this is not actually how any physician or medical student or resident is ever taught to hold the scalpel. We never hold it like this. You always hold it like a pencil because you just have better mobility in the way that you hold the knife. And you would actually have your left hand stabilizing the trachea above where you're cutting. You would make your vertical incision like this and then stab horizontal incisions, and then you would stick your finger directly into the hole so that you have enough time to take your other hand and push a bougie down into the hole. And then once the bougie's in there, then you would replace that with a smaller tube, typically like a 6.0 endotracheal tube into that hole. Again, if you want to see this demonstrated in a real simulated airway case, you can refer to that other simulation video that I referred to earlier.
Got an unresponsive unhoused man coming in.
No signs of trauma, no ID.
This is something that we see very frequently in the ER, working the city, inner city very frequently as well. Very often it is substance related because homelessness tends to coincide with mental illness and addiction. If you think of it like a Venn diagram, those three things often overlap very tightly. That being said, it doesn't always mean that the person's coming in because of intoxication. So you still need to do your due diligence by making sure that they haven't been like struck in the head and you're not missing like a bruise or a brain injury. You're doing blood work and you're not missing any kind of metabolic abnormalities that might be causing the decreased level of consciousness. And then only after you've ruled out all of these other things can you say that you've ruled out the big bad scary things and that this is probably just related to maybe alcohol intoxication or opiates or some other substance, and you let them sleep in the emergency department to clear the intoxication and then send them on their way when they're more awake and able to walk. Dude. So, okay, just a little while ago, I had a patient that came in and he had, I think, a rat that was living inside his hoodie, and it was his pet rat, and the rat would come out.
The department would never admit rats unless they have the right insurance.
He's an unhoused man, lives almost exclusively on dollar store ramen. There's parafollicular
Dollar store
hemorrhage,
ramen.
gingivitis, bleeding gums.
I feel
and,
like
yeah, no fruit or vegetables in
the
his diet.
season 1 of the Pitt incorporates a lot more of the dark humor that we actually use in real life, more so than season 2. It's actually pretty
Now that
funny.
you mention it, there was a smell.
Probably a pyrite. Captain Scurvy's got a vitamin C deficiency. Cheapest way to fix it is with a daily supplement.
Drug-seeking woman kicked off a city bus for disrupting and disturbing passengers. She's been screaming for narcotics nonstop.
Please, I have sickle cell.
Probably coming in with a sickle cell pain crisis, and she's been mistaken for pain-seeking or drug-seeking behavior. So this is one of the unfortunate things that we see in healthcare is people with serious medical concerns are disregarded and kind of brushed off as drug-seeking. And unfortunately, sickle cell crises are one of those things.
10 milligrams of IV morphine.
You really want 10?
Yes, repeated in 5 minutes if needed, and she needs a dilaudid drip. This is a vaso-occlusive crisis.
What happens with people with sickle cell is that during an infection or some kind of stressful event, the red blood cells can actually turn from a round shape into sickle cell, which are kind of like crescent moon shape. And because the crescent moon shaped cells don't flow smoothly through the blood vessels, they can actually cause essentially like a traffic jam of red blood cells, which essentially blocks the flow to different areas, whether it's to your fingers, to your chest, to your abdomen. You can get strokes from it, and this causes severe pain and can sometimes actually cause other severe deficits. One of the quickest ways that we would treat this is with IV pain medications like IV morphine or hydromorphone, which is what Samira ordered. The other thing that we would do is we would give the person 100% oxygen to try to convert the sickle cells back into round cells and decrease the amount of, I guess, like hypoxic stress on the blood cells.
That only works once an hour, though, so don't go crazy.
Could I confer with you?
Yeah.
Jeez, that's so bad.
You seem surprised by the opioid dosage.
Drug
You
seeking.
can't fake a hemoglobin of 6.
Yeah, at least Whitaker is receptive to
Anterior
feedback.
compartment.
I do like how they're including a lot of the kind of softer skills in medicine, like even just the language that Whitaker uses and the attitudes that are presented by healthcare workers, like don't go crazy with the pain medications is such a bad thing to say directly to a patient, you know, so yeah.
Power line fried his arm and the current through his whole body stopped his heart.
Okay, so this guy's coming in with a high voltage electrocution injury. If the guy was electrocuted in his arm and, you know, the only other place where he was grounded was his feet, then you would think that the electrical voltage would have come from his arm through his chest cavity down to his legs. So you'd be looking for essentially bad electrical burn injuries during that through that entire arc or tract of electrocution. There's all these different life-threatening irregular rhythms that your heart can go into, and so that's why we put the person on monitors and get ready to shock them again with more electricity to actually press the reset button on the heart and get it back into the normal rhythm.
Add a myoglobin and a CK to the labs.
So myoglobin and CK are really important. Myoglobin tests for any signs of muscular breakdown or rhabdomyolysis because electrical injuries can cause all the muscles essentially to either fry or go into spasm and then break down, which releases myoglobin, and that can actually clog up your kidneys and cause your kidneys to go into failure. The other thing that she ordered was a CK, and that's another marker to look for rhabdomyolysis.
Rhabdomyolysis from tissue damage can kill the kidneys. Ongoing risk of cardiac irritability.
Excellent.
AP pad, hence ventral compartment.
Charge to 300.
They're saying charge to 300. That means that they're using a monophasic defibrillator machine. Most places in North America actually use biphasic machines, and the maximum dose of electricity is 200 joules biphasic on those machines. The maximum dose on the monophasic machine is 360, but you just don't really see those around much anymore. The other thing that they're alluding to is that the person has really tense compartments on the of the forearm, which makes you think that the person might have compartment syndrome. And sometimes what we'll do is we'll actually perform a fasciotomy where we use a knife or a scalpel like this thing to actually cut along the surfaces of the arms to allow the muscles to bulge out so that the circulation isn't cut off and all the tissue dies.
Fasciotomy.
So again, she's holding the blade wrong. Most surgeons don't hold the blade like that. But it is actually accurate that even if someone hasn't actually seen a procedure, we would allow them to do it with very close supervision.
Hey, Bennett, wake up for me.
Unknown downtime, he was sleeping in the hall.
The guy was left there unmonitored and in cardiac arrest. You have no idea how long the guy's been in cardiac arrest, so prognosis is going to be very, very poor.
Resume compressions.
And asystole is also not a shockable rhythm. The chances of survival in this kind of scenario are really, really poor.
Pulls are fixed and dilated.
Been down a long time. 3 rounds of epi and then call it.
Losing your first patient can be really, really difficult. I think it is quite nice that Dr. Robbie is allowing Whitaker to run this code. The chances of this person surviving are slim to none. I mean, the patient's already dead. But I think that Dr. Robbie's probably allowing Whitaker to continue trying to resuscitate this person with multiple rounds of epinephrine and chest compressions because he understands that probably there's a lot of associated guilt and he's trying to mitigate the amount of psychological trauma on Whitaker moving forward.
You ready to call this?
Not yet.
Damn, Whitaker. All right, season 1, episode 2.